Okay, wonderful. Hi, everyone. My name is Tarin. I use she, her pronouns, and I'm one of the knowledge and research leads at the Center for Innovation in Campus Mental Health. I am here for our clinical supervision webinar. And before we begin and turn it over to our lovely speaker, I want to go through our land acknowledgements. So I know we're all here in a virtual session today, but we are joining in from the ancestral lands of many Indigenous communities. I am currently in Toronto, Treaty 13 territory, and the home of the Anishinaabe, Haudenosaunee, Wendat peoples, the Mississaugas of the Credit, the Chippewa, and the people who may still be unrecorded. As a settler myself, it is my duty to acknowledge the effects of colonialism that we still see today, the ways I may be participating in it, and the ways I can actively push back against it. As I go through this webinar, I want you to think about how you might be able to support Indigenous students and colleagues in your role to promote a whole campus approach to health and wellness, and also be an active participant in the reconciliation process. So this can look like participating in education on Indigenous peoples, their culture, language, arts, worldviews, and supporting organizations that help Indigenous communities. So I'm going to turn it over to our speaker. I will again put the housekeeping that I mentioned earlier in the chat, so you can take a look at that. But yeah, Karen, I can turn it over to you now, and you're welcome to take it on.
Thank you. Good morning, everyone. I'm really pleased to be here with you and talk about clinical supervision. My name is Karen Sewell. I'm an assistant professor at the School of Social Work at Carleton University in Ottawa. I started my involvement with clinical supervision when I was working for about 17 years in children's mental health. And during that time, I supervised, actually prior to that, I was supervised, provided supervision, trained and supported supervisors, and then decided to go back to school and do a PhD where I focused my research on clinical supervision specific to children's mental health, a specific program. And I really got interested and excited about the information that was out and available for supervision that I actually didn't have access to, for the access or probably awareness about, for the first 17 years of my social work career. So with that, I really made clinical supervision the focus of my program of research and get very excited to think and talk about and research clinical supervision. So I really appreciate the opportunity to be with you here today. I've got a slide deck that I'm going to go through, and so I'm going to share that and actually talk a little bit about what I was thinking for today. Give me a second. There we go. This is what I was thinking in terms of objectives, is that there's an opportunity through the information that I'm sharing to gain, enhance, reinforce, reconsider knowledge of supervision research and theory, reflect on people's past supervision experiences, supervisory relationships, and areas that can impact the working alliance. Consider the best way to prepare and make the most of supervision. I'm going to share some work that I've done with the Canadian Mental Health Association Ottawa Branch around developing a model of supervision to use in that organization, and then provide some information about some supervision resources that I think are great throughout this conversation. My hope is we can use the chat function to really share additional resources or thoughts to benefit. It's very weird to do a webinar for me where I don't get to see people's faces. So perhaps we can start. Taryn, can you put up the poll just to get a sense of who's what that with us in the audience around sort of what people's roles are? So Taryn's going to do that, and then we'll get started with some of the other pieces too. So if people just, sorry, we're up.
Sorry, just want to tell folks that it's up.
If people can just take a moment to do that, then we can gain a sense of who's with us here. and I sort of went through the objectives. The agenda is really, really closely tied to that. So if there is anything that you see on this agenda that you're thinking, I very much want to cover that, or I was hoping we would cover something else, if you want to throw that in the chat while we're waiting for our poll results, we've got a little flexibility in what we're talking about. Do we have our results yet?
I think we have our results. I'm just going to end the poll in a second. Yep, now end poll, and I will share the results right now.
Okay, supervisor, frontline staff, that looks like our biggest group. Okay, wonderful. All right, so fantastic. We'll go through these slides, and depending on your role, if there's something you're interested in or have questions, you can capture them. We do have time later, or we can take a moment and address them as we go. So I'm gonna start us off with a little bit of an overview about what's available with regard to supervision theory. So I say supervision, there are a lot of different terms that people use, and people use quite differently. So clinical supervision is one of the, was in the title of this webinar. And when people are talking about clinical supervision, the way I understand it is it's really with a focus on the work that people are doing related to clients, and that in the literature, it's defined at the bottom left of this slide. You can see 4 functions, and that is really what is made up of clinical supervision or professional supervision, ongoing supervision of staff. And it's really about administration, professional development, support, and quality of care. So when I'm talking about supervision, I'm going to use that as short form for clinical supervision that encompasses those 4 functions. So in the literature, there's really the information that probably most of you know, but workplace-based supervision functions within an organization hierarchically with an assigned supervisor who develops a relationship with a staff member, and through this relationship, they engage in these different functions. So they talk about admin paperwork and taking vacation and things that actually contribute to the work that the frontline staff member does. Talk about professional development of the practitioner, talk about the support needed in often really challenging situations with clients or within the context of the resources available. And then also talk about the quality of care. So case conceptualization, planning, challenges that clients are experiencing. And through doing this in the relationship and meeting and talk about practicing skills in a bit, the supervision then is sort of conceived to enable practitioners, workers, staff members to provide the best possible service to clients. And then those clients are able to best reach the goals that they set them for themselves. So those client outcomes. One of the things that I've been thinking a lot about in the research that I'm involved in is what workplace-based supervision can is sort of connected to, responsible for, contributes to the wellness of staff. And I'll get to that in a little bit, but how what a supervisor can do can actually either increase or decrease compassion, satisfaction, perceived support, burnout, secondary traumatic stress, and moral distress of practitioners that supports their involvement in the work that they do with clients. So this is kind of the conceptualization that I am using around this. So what I'm going to do before I start talking a little bit about the research, I'm going to ask everybody to take a moment and think about your own supervision. So the supervision you've had, whether it was a student, a trainee, or a staff member, and share one characteristic of really great supervision in the chat. So I'm hoping people can just write down something, whether it was about the supervisor or something that happened within supervision that made it really strong for you. So I see supportive, thanks, Peggy. Safety and non-judgmental space, a strength-based approach, the person cared about your success. The ability to provide clinical direction is what I'm assuming. Provide clinical stretching for exploring other alternatives, continuous check-ins, reflective questions, trust, safety, and vulnerability, support, vulnerability being honored. This is wonderful. And this is a question attuned to my values as a social worker, honors vulnerability, safe to share questions and doubts, supportive but ask good questions about next steps. So with this, my hope in asking this question is really for people to reflect upon supervision. Some of the information that is available in the literature is really about how people engage in supervision based on the supervision they receive. So if you have received supervision that sort of meets those qualities, chances are you felt supported, you felt better able to do your job. But if you've had experiences that were vastly different from that, those are some of the experiences you carry with you into supervision as well. So with that, when people walk into supervision in that supervisory dyad, so the supervisor and the practitioner, staff member, worker, they're bringing in those experiences of supervision. And when we talk about supervision in practice, what we're seeing is that generally speaking in the literature, they talk about how supervisors basically haven't had that much training. What they do is they try and replicate those things that they have experienced as positive and try to steer clear of those things that they think of as problematic. And with that, most people don't have a connection to specific research or literature or models of supervision. But what we're seeing a little bit is that in the research, there's a bit of reinvigoration and people are paying more attention to supervision and supervision research. I'm going to go back quickly just to talk a little bit when it comes to research about what is out there that supports this understanding of supervision. So when it comes to workers, there's some good knowledge syntheses out there that talk about how supervision really increases job satisfaction, organizational commitment, worker self-efficacy, retention, improved well-being, and it also decreases some of the things we don't want to see for practitioners. So it decreases job stress, burnout, worker anxiety, and depression. When it comes to being able, and little arrows are a little off. We look at what that means and what that can look like in terms of the service that people are providing. Most of that information comes from implementation science. And what's demonstrated there is that people are actually better able to implement specific programs because of the supervision they receive, that with specific models, there's actually a decrease in some of the targets of the intervention for clients. There's a bit of information out there in different models where there's not really a relationship to worker outcomes, to client outcomes, but workers end up doing better in terms of being able to deliver the programs. When it comes to client outcomes, there's a really great little bit data, but really great randomized control trial that demonstrated that specific type of supervision reduced depressive symptoms for clients. And when they do some naturalistic studies, and I looked at this across and some knowledge synthesis across a lot of different studies, they show that client outcomes actually are connected to supervision to the tune of 1% to 16%, meaning that variance in client outcome can be directly attributed to supervision. The one that you actually can't see very well, that human weighing one, is a knowledge synthesis and found that 4 to 6% of client outcomes can be connected directly to supervision. Now, that doesn't seem like a lot, but when we think about what can be controlled and think about what can be attributed with all the other factors that come into consideration and play when looking at client outcomes, it's not insignificant. Well, it's significant statistically, but it's also substantial in terms of having an impact. Now, in terms of organizational outcomes, I'm not going to get into too much detail about this slide. Just want to point out that this is the team that I'm involved with. We looked at 175 studies to look at the impact that supervision has across outcomes that are important to organizations. We had a group of about 20 leaders from different organizations in Ontario come together to talk about what was really important, and that guided some of the work that we did on this. And you can see that first one is problematic worker outcomes, and we've got positive worker outcomes, formal organizational outcomes, and service-related worker outcomes. And just to sum this up, when you look across all of those different outcomes, supervision is really showing strongly to impact workers. And so what we found is 63% of these outcomes measured across the 175 studies ended up demonstrating that supervision had a real benefit for workers. So those negative things like anxiety, burnout, depression, those decreased as a result of supervision, where things like ability to cope with stress, professional development and growth, those things increased with supervision. We saw things like the organizational climate improve. We also saw across these studies that effectiveness and competence for practitioners also improved. Interestingly, we saw 63% of these really had that beneficial outcome, and only a small percentage, 3%, had a negative outcome. The rest were kind of mixed, and that's because oftentimes supervision, both in research as well as in practice, isn't well defined. Meaning, if I say supervision or clinical supervision, you may have an understanding based on your own experience about what that means. And we kind of make assumptions and presumptions. Same thing has happened in a lot of the research. They're not defining supervision. They're not really figuring out what that means. So that's really what's been guiding some of the work that we're doing. So we're looking at supervision in practice in Ontario. And I'm just going to go through a couple of things. We looked at human service organizations. So that crossed a whole wide range of organizations. So education, and we had participants from post-secondary education, we had child welfare, we had housing, we had mental health, behavioral health in different ways represented. We had 263 practitioners, 85 supervisors, and 27 leaders respond to a survey that took place just over a year ago. And what we found was 80% of the people who filled out our survey, practitioners, indicated they received supervision. Now, really only 40% of the people that completed it said they were satisfied with supervision. 84% of supervisors received supervision and 81% of leaders received supervision. And what we found was the people who didn't really spoke about how they didn't receive it because either there was a lack of support or capacity in the organization. And so we were sort of curious. So that's why people aren't getting supervision. For the people who were getting supervision, we were really interested in understanding what they meant by supervision and what that supervision looked like. So what we ended up doing was asking people those 4 functions that I talked about with the theory piece. So that is administration, professional development, support, and quality of care. We really wondered what people felt like they were getting in supervision they received. So we had 41% of the practitioners who got supervision said they were getting all 4 areas or functions of supervision. Now, when it came, we couldn't link the samples. So we don't know if this looks very different or if there's a different perception about what is happening based on role. So while 41% indicated they received all those 4 aspects of supervision, 73% of supervisors said they were delivering supervision that targeted those 4 areas. And then 96% of the leaders indicated their organizations offered supervision to staff that provided those 4 areas. So what this really tells us is there's a bit of a disconnect around people's understanding of supervision, perhaps, or a bit of a disconnect. Like, supervision is happening, but what's the quality of supervision? What's the understanding of people with regard to supervision? And what does that look like when things are challenging? Organizations and people are running, literature tells us, with less staff because of either vacancies or leaves. For the clients that people are seeing, the challenges and complexities are increased. And so there are real challenges for people to receive training, receive support in organizations to provide supervision or clinical supervision that really contains sort of that rich, comprehensive supervision and the best practices related to that. So then when it comes to one of the things we were interested in, we were really interested in understanding what that connection between supervision and wellness was for practitioners. So what we ended up doing, we had a couple of measures in the survey that asked about detail related to supervision, and also, so that's a Manchester Clinical Supervision Scale. We also did the ProQual, so the Professional Quality of Life Health version, asking people about domains of wellness. And this was another interesting thing that we found. I'm not going to get into all the stats on this. People are interested in methods or like the stats findings. Perhaps you can ask that in the Q&A and I can touch more upon that. But what we found, we used this cutoff with one of the measures to decide or determine whether supervision was considered effective, ineffective, and with though it was sort of that cutoff, we grouped participants into 3 separate groups. And we had 207 participants that we were able to do this with because of full completion of surveys. And what we found was people who received effective supervision did far better across the board, in the 5 domains of wellness we were interested in. So again, that's compassion, satisfaction, perceived support, burnout, secondary traumatic stress, and moral distress. They were doing better and statistically significantly than the other 2 groups. The part that maybe is a bit intuitive, but it's not really demonstrated in the literature, is people who received no supervision were doing better than the people who received ineffective supervision. Again, our main pull from this finding was that when supervision is available as a resource, to have people, and got 50% of our folks on the call today who are delivering supervision to frontline folks, is to really think through and intentionally engage in supervision that is comprehensive and is meeting the needs of staff, because it's that contributes to these better domains of wellness. So we're right in the middle right now of analyzing that data to look and see what it looks like for the different functions of supervision, and if engaging in the different functions of supervision has an impact and what that contributes to in terms of practitioner wellness. And what we found, we've got to check one more stats piece, but what we found is that the normative function that aligns with sort of administrative function is really having the biggest impact. Sort of, which was kind of weird. I would have thought the supportive piece did. But when we really pulled back what that meant, it meant if people were getting regular supervision and they felt like their supervisor, this is what we're sort of putting out to the world, felt like their supervisor was able to help them manage some pieces of their job, like that tangible kind of stuff, like my caseload is too high. I don't know what to do with this. There's crossover with quality of care, but with that piece around normative, it kind of gets captured there. And so that then has the kind of responsible for the most of the variance or most of the impact on those wellness domains. So this is something that we're continuing. So we did the survey, and then we finished in the fall interviews with both supervisors and practitioners to really look at what people are doing that they feel makes a difference to these areas of wellness for workers. So stay tuned. We'll have information about that hopefully in the next couple of months. So I wanted to touch upon that. I also wanted to touch upon some work that and uh, Maria and Sarah Lindsay and Nishaba Degani and I did around the Canadian Mental Health Association in 12 branches, where we looked at really what was going on in practice to see what it looked like. Now, I'm not going to get into all the stats on that, but I thought this might be pretty relevant for this group, is what of that group of supervisors, so it's 125, as well as 35 leaders, so directors and CEOs, talked about that really facilitated supervision on an organization. And so as we get into what some of the best practice information is, thinking through, there's some organizational pieces that need to be in place to support that. So what supervisors were talking about was they were able to do this kind of more full, comprehensive supervision that allows people to feel supported and allows that sort of connection to wellness if they had a culture that prioritized supervision, wellness, and environment, that there was an intentional investment in organizational supports, so policies, procedures, models, tools, resources, and that supervision was something that was known and supported at all different levels so that people could feel supported. There was knowledge about best practices, there was education and training opportunities, and that they got support from the person that provided supervision to them, as well as from their peers. When we heard from leaders, what they spoke about, again, was this culture of clear, consistent, formalized values and expectations related and procedures related to supervision. So having some kind of standardized way of delivering supervision, having protected time, access to learning and support, dedicated roles, and having some way to support that. So that was something we're sort of talking about and figuring out how to really support people. So now we had people reflect on a characteristic that they thought was related to the best supervisory experience they had, talked a little bit about what we characterized as effective. And I'm going to get into some of the best practice pieces in a second, but I want to take a moment for people to see if they have other ideas outside of sort of that characteristic or attribute that you would consider impacting or setting the stage or contributing to effective supervision. Oh, I'll get back to that, Mira, after, but I'm inviting everybody right now just to pop any thoughts they have around what makes for effective supervision. Now, and I'm recognizing it might be crossover, but I'll take a moment. Dedicated scheduled time that doesn't get canceled all the time. Tricky business, but so important. That's what we see connected to that sort of normal function. Clinical expertise and knowledge, uninterrupted time, accessible. Yeah, let people put those in and we can look at them a little bit later as well. And just having the ability, having somebody to go to, some time, unprotected time, somebody with some expertise, and somebody with the ability to focus is really important. I'm going to go through a little bit of what's out there in the literature. So it's kind of connected to what people were sharing, but having the opportunity to debrief after challenging events and someone to connect with to really gain a better understanding of either clients or events, someone who takes the time and encourages career development. And when it comes to those facilitators, that open, supportive, safe environment that we heard about related to best sort of qualities, a supervisory relationship based on trust and connected again to what everybody shared. It's having that regular supervision and timely feedback. Some of the common elements and gold star strategies in supervision sessions in the literature are agenda setting. So taking that time to really be collaborative and set a focus for supervision, having an opportunity to do some skill building and behavioral rehearsal. So that's a sort of professional development piece, but people feeling really prepared because they've had a chance to try some things out. That review of work and being able to practice focused discussion, review and monitoring outcomes for clients, getting feedback, and also receiving feedback about supervision. So that real reciprocal feedback so that practitioners, frontline staff are able to say, this is meeting my needs, this isn't meeting my needs. You know what would be more helpful for me is if we could focus some of our time on X, Y, or Z. And some dedicated time to attend to the supervisory relationship. In the literature, that comes across so clearly as the one mechanism through which supervision happens and happens effectively is the quality of the relationship between the supervisor and the staff member. And so that's sort of broken down into supportive listening, getting feedback, and then having an alliance that's based on power. So being able to discuss what happens, some real clear understanding and transparency around what goes on in supervision, where that goes, how evaluation is happening, that sort of thing. So oftentimes when I sort of present these pieces, I also think it's really important to touch upon some of the literature out there that talks about unhelpful as well as inadequate and harmful supervision. So when I think back to the survey that we're still analyzing in Ontario, finding that there is a group of people, like large group of people, about a third, who are experiencing ineffective supervision. So what's shown in the literature is that, just the flip side of what people put in the chat, but inconsistent and unreliable supervision is very unhelpful. Lacking opportunities to reflect on the work. So oppressive practices, that's a sort of, it kind of connects to micromanagement, but really having entrenched views and not being open to understanding the staff or practitioner's perspective, and micromanagement so that people feel like they're not being supported. Rather, somebody's looking over their shoulder and really telling them like what they need to be doing. And quite frankly, when it comes to effective as well as unhelpful and ineffective supervision, I've had them both, and I can say in terms of inadequate and harmful supervision, so this is a sort of section of literature, and there's people that really focus in on this, and really defining inadequate and harmful. So inadequate meaning people really are not receiving benefit from it. So either the supervisor is unable or unwilling to engage in this stuff. And then harmful is when practitioners are being harmed by what's happening in supervision. So with that, depreciating supervision. So not having dedicated time, not seeing, and this is a supervisor, not seeing the need to be available and providing supervision. Supervisor doesn't have an accurate conceptualization of the work. Supervising the supervisor. So this is where the supervisor is using that dedicated time to talk about what's going on with them, perhaps organizationally, versus the focus being solely on the practitioner and their work. Inappropriate boundaries, so that can be either work related or beyond that. And this is where we're getting into a harmful piece. The abuse of power, so being threatened, sexual impropriety, discrimination, destructive feedback, that's shaming or pathologizing the supervisor. So in one of the most recent studies that's quoted there, over half the participants experienced harmful supervision at some point in their career. So that's the one, that's kind of the last three. My takeaway, based on sort of some of the discussion from the authors and researchers on this, is really that we're all capable of engaging in inadequate and harmful supervision at some point in time. So being able to acknowledge that it exists and being reflective on that as supervisors, as well as having peers to talk about this, is super important in terms of protecting people that are being supervised. I'm just looking at our time. I'm going to take a minute to go through and think about the supervisory relationship really being the key mechanism. There's a lot of information out there around that interactive nature of the supervisory relationship. So here, Larry Shulman's quote, one of his, dynamic interaction in which, this is about supervision, dynamic interaction in which the supervisor and worker constantly influencing and being influenced by the behavior and expressed emotion of the others. To me, this is so important in a work context because these relationships can often be for an extended period of time with that difference related to like supervisee or students in a work setting. They can go on for a really long time, and having people really think through how they're contributing to the relationship and what that looks like is important. And I think there is a body of literature out there that talks about, so we say supervisory relationship, that often in their research, because it kind of is easily researched, they talk about the supervisory working. So that is really about the bond, the emotional bond, and the agreement on tasks and goals within supervision. There's sort of another body of literature around the real relationship, meaning not necessarily what happens in the session, this stuff that happens in the session, but that there's also a relationship that is formed based on who people are within the organization. But really, there's some information out there around things that supervisor does to contribute to developing the supervisory alliance. You can see some of those things that people talk about in the personal and professional attitudes. So really, when we see honesty, genuine, acts with integrity, demonstrates competence, approaches with humility, a lot of that relates to what supervisors can do that ends up resulting in trust and in safety. And that we see too with respect to the attitudes of interpersonal relational, so respectful, warm, empathetic, trustworthy, effective communicator. And then really is able to, going back to that best practice piece about agenda setting, really makes it a collaborative environment whereby there's consensus and people really understand what is going to be best for that supervisory relationship with diet. The idea of being able to show diversity and multicultural awareness, transparency around power, gives feedback, promotes learning, respects boundaries, and then addresses any strains that occur within the relationship. I'm just thinking of our time, and I'm not going to spend too much on this, but this is where there's a review of the literature that really talks about factors that both the supervisor and the supervisee do individually, but then together that contributes to a supervisory working alliance that's really effective. I'm going to switch just for a second because one of the things that, not switch for a second, move on looking at our time, but one of the things that actually is key when we talk about the supervisory relationship is a supervisory agreement. There's a lot of contract, it's called agreement, but how having some explicit discussion and mechanism to really talk about what supervision is, what people's expectations are, how authority and power are addressed in that relationship, and how feedback will happen is really a crucial, important piece of setting up the supervisory relationship and reviewing it. So I'm going to What what I'm going to switch us into a little bit is how that information has really impacted, influenced, and contributed to an understanding that has been developed with the Ontario branch or Ottawa branch of the CMHA, where there's a group of us there and then myself who've been working on developing a model of supervision organizationally to really embed these best practices and create organizational conditions that really fosters clinical supervision. I'm going to touch upon this just briefly, and then we can get to some resources that can be shared from this model, but also then invite a bit more sharing across the group. So this model really articulates an approach. So there's a commitment organizationally to providing internal multimodal supervision that adheres to principles and has integrated theory in it. So you can see those modalities at the bottom. So people within the organization receive individual supervision, and this is at all levels. So we're working on the executive director, the directors, the program managers who provide supervision and frontline staff across the board receive individual monthly supervision. They have resource teams weekly, and there's an ad hoc ability for people to get supervisory input and support when needed, sort of on an ad hoc basis. And they've got a couple of things that support that. So they've got clinical incident debriefing and on-call supervision. So if the manager isn't available, that's available. They've set up a clinical consultation where anybody in the organization can come and get some. There's one of the program managers runs that, but there's support for clinical needs of frontline staff. And then through this model, also receiving supervisory training. And then there's a supervision community of practice where supervisors come together in a peer model every 2 weeks to talk about and practice skills, to share some of their successes, and then do a bit of problem solving. And so this model, and I want to highlight the work that CMHA Ottawa has committed to doing related to this. And talk about supervision and those structures organizationally that allow people to have the time and that uninterrupted time to gain the support they need. It really is an organizational commitment that makes this happen. So we followed a framework from Yale Program of Supervision to make this happen. Really, really looked at what was happening within the branch through a strengths and needs assessment. Got shared buy-in, leadership, and then we ended up doing staff focus groups, and then really looked at this being an ongoing organizational change that requires commitment to, and they've committed for this to be a 3 to 5 year process. So we're in year 2 of this. We've seen lots of changes, and then we continue to need to work on what else needs to happen. So when we're talking about organizational change, if supervision is something that's not embedded, really needs to be a focus, discussion point, and support within the organization. So these are the principles that I'm not going to go through, but that really are crucial and important to make this happen. Just to point out the training that this group did, it was 8 half-day sessions, and we really focused on some of the foundational pieces of supervision, but then through the strengths and needs assessment, identified some of the topics that were really important for folks, and that made up our supervisory training. And so we did that, but when we did that, we really recognized other things that tap into support. So when ongoing learning, one of the things that was super valuable from my perspective and hearing from people within the branch, it's that idea of ownership, co-creation, and enthusiasm happening at the branch level so that people really feel committed, connected, and are involved with this. There's an awareness and ongoing discussion about supervision, what that looks like, how to make that happen. There's a value of supervision and skill practice that's embedded within the organization. We've really gone back and forth and thought through language, whether we call it supervision, clinical supervision, what happens across the board. So with this, all their teams, whether they're directly providing service or not, are on within the supervision framework and getting involved with this. Staff are involved. We've been thinking about sustainability and how to move this forward. So we also, just really briefly, we ended up doing individual consultations with people. We've done post-training series of focus groups, leaders and staff. We've added training for the enabling teams. So those are folks that make the direct practice service portions of the organization work. We've done staff training for supervision so people understand what the model is. We've done a lot of work with the different groups, so directors. We've got a structure and support for the community supervision and practice. We created the clinical supervision or consultation group, and we're continuing to look at how to support this. Now, from this model, well, first of all, I am going to invite people to share any supervision resources, so training, tools, access to information. I'm going to invite everybody to put them in the chat as I go through a few things just to sort of summarize some of the things that I think are brilliant resources. And then maybe we can just talk about, you put them in the chat, things that have been really helpful for you or things you're aware of. We can compile these resources and share them as sort of a post-webinar piece. So when I talked about the supervision model, talk about a supervisory agreement. One of the things that we did with CMHA Ottawa is come up with a template to guide discussion, because it's not about a checkbox piece. It's about having the discussion and really engaging conversation in that supervisory dyad about some important points. So we came up with a template that's sort of been tested out and adjusted. That's something that I've got my contact information at the end. The Ottawa branch is happy to share. So if this is something you're interested in, connect with me and we can share that. The Ottawa branches also come up with a supervision session document that goes through and incorporates the best practices. Again, this is not meant to be prescriptive, but just kind of cues and prompts that make sure people are doing this. This is a tool they're up for sharing if you want to contact me. In terms of thinking about supervision training, I'm going to really finish this in a minute and a half and have Q&A time. But I know there's a lot of training now that's sort of popping up in relation to regulation stuff that's happening across the province, some well-established programs. One of the things I know with Maria we've talked about is really what some of the important things are to consider when you're looking at supervision training. So in the training, what is their approach to supervision? Does that match what yours is? What is the person's approach to training? There's some best practices around supervision training. Is that happening within the session? Some modeling, role play, giving feedback. Is it being used and taught in the session? And then thinking about one of the things that I think happens a lot in our field is we go to a lot of trainings, but don't always have mechanisms to practice that when we go back to our work life, and thinking about how to generalize some of the skills. So those are some of my thoughts around thinking about supervision training. There are a few, these are two texts that I think are brilliant for organizational supervision. They call it professional supervision, those two books, and we'll put that in a resource list. There's also some of the work that we did really looked at supervision competencies. And this is a tool that people can use. It's freely available, and you can just kind of do a self-rating and check it out. I am going to just realize this should not be on here, but this should be on here where there's some resources where you can score it. It's pretty easy and it's really helpful in understanding some areas that people might want to reflect and work on. I'm talking a lot about wellness. There are a couple of great resources. There's the ProQual. They have some fantastic resources when we talk about those 5 domains of wellness. Attend Academy, Francois Matthews work out of Kingston. They have some very cool wellness resources. And then this is just an example. There is a lot of information out there. There is a website here about different supervision competencies. I'm not going to go through them, but they're things that people can access if they want more. So that is where I'm going to stop, and we can go to, I'm going to turn this off and we can go to a little Q&A.
Thank you so much, Karen. I did get a couple of questions
Okay.
and comments. So one of them was, Karen, if you're able to put your email in the chat,
Mhm.
people have been wondering about that. And maybe you can send me the resources that you've sent, and I can put that in the website
Absolutely.
when it's uploaded, and folks can access that.
Okay.
I also have a couple of comments on the Q&A. So Vicky said, check out the supervision certificate training at U of Calgary, U of
Beautiful.
Laurier. So those
Beautiful.
are resources that were highlighted. There's also a question. Can you share more about the CMHA supervision training?
So the training was specific to the Ottawa branch. That's what we're talking about.
Yes.
Yeah. So it was specific to the Ottawa branch. And what we ended up doing was that 2.5 hours for 8 sessions, and we did it every month. So with that, there were some didactic pieces. So I'd present some information specific to those topics that we covered. And then there would be practice. So we did role plays each session. We did some case studies and application and did some small group stuff. And then between sessions, people had a practice activity and then we reviewed it. So what we did for each of the topics was really, I would go to literature, compile some stuff, present it, we talk about it, we'd apply it. And that was for their supervision group. So that was kind of program managers, directors, ED at the time, or CEO at the time, would come and do that. So that allowed us really to dig into the model, but then some of the knowledge related to that model. And then what we ended up doing was staff were getting sort of, they had a mixed understanding. So we did 6 1.5 hour sessions, not for everybody. The 8 participants completed the 8 half-day sessions. But for staff, they completed a 1.5 hour session where we focused in on a little bit about what they could do to support a better relationship with their supervisor, their pieces around what they could do to prepare and make the most out of supervision, and how they could give feedback to their supervisor. And then for the enabling teams, we looked at real sort of connection between supervision, human services, but then also some management leadership, how sort of things aligned or what they could do to support that. In a nutshell.
Wonderful. We have another question, hopefully not too complex a question, but is there a guideline / resource on how to strike a balance between providing supervision to a counselor with vicarious trauma and suggesting they receive personal counseling support without creating shame?
Okay, so that's no quick answer, but I think some of the stuff that we're seeing is just the importance for supervisors, and I'll add a couple of things to that resource list, to be able to recognize the signs of secondary traumatic stress, vicarious trauma, compassion fatigue, burnout, and have the emotional connection, or sort of the emotional components of the job as something that's focused. So with that, talking about some of the emotional pieces related to the job, specific client stuff, is kind of the purview of supervision. But then when it starts to impact people's ability to do the job, or there are things outside of life, and that's coming into supervision, that being the piece, one, normalizing that that's going to happen in this work, and that supervision is something to be able to talk about a bit, some of the emotional challenges of the job, but when it goes into things that are impacting the job or impacting somebody personally, it's really normal within this line of work, and it's why we have EAP programs, to be able to access some counseling to support people. And so to normalize some of it, I think to that shame piece, but to really normalize it as part of the job that emotions come into this. And sometimes they end up really impacting people's ability to do the job. And that's where having some additional support is meant just as that, to support people. I don't know if that's helpful, but I'll put some, because there's information out there. So I'll share that, and that can be something too around that.
Amazing. Um, I just sent a clarification question on one of the other questions that were on here, but in the meantime, I want to thank Karen so much for this wonderful presentation, very enlightening, very informational. And again, folks, you can find the recording at the end of the day on our website. And after the
Thanks,
end of
Patty.
the webinar, you can fill out our evaluation, provide us feedback, what you'd like to see more, along with any of the other previous webinars. You can check it out on our website. I'm just going to put that in the chat. And you can find the resources that Karen mentioned on there as well at the end of the day, along with the recording. It doesn't look like there's any more questions, so I think we will end it off right here. Again, Karen, thank you so much for coming here and talking about this, and thank you so much for everybody who is here today and joining us. I know it is right before the long weekend, so I really appreciate your dedication. So I hope you folks have a lovely weekend ahead, and I will see you next month.
Could I just say something really quickly? Could we
Yeah.
commit to the resource list on Tuesday?
Yeah, absolutely.
Perfect. Okay. Because I'll fill it out a little more fully. Okay.
Amazing. Thank you so much. Okay, folks. See you.